Hello again, and welcome back to another episode of Oncology Brothers Podcast. I'm Rohit Gosain, and here with my brother and co-host Rahul Gosain. We have recently covered quite a few different topics in heme malignancies ranging from leukemia, myeloma to lymphoma. I think one of the things that we as a community oncologists, or I personally struggle with, is managing some of the side effects from chronic aspects, especially when it comes to transplant, because we don't tend to see these patients often. And one of that topic is GVHD, a complication we see after allogeneic transplant. This can be in acute settings or chronic settings, and historically, we've had limited treatment options for this. But recently, we have seen a new approval in the space, and over the next 15 to 20 minutes, we will focus on this particular drug, which is called Axatilimab, a novel monoclonal antibody approved based off of AGAVE-201 study. To cover this, we are joined by none other than Dr. Shernan Holtan from my home institution, Roswell Park Comprehensive Cancer Center. Shernan, thanks so much for joining us.
Thank you so much for the invitation. I'm excited to talk about this drug and about a little bit about transplant in general. It's a whole new era. We should talk about that.
Absolutely. Shernan, welcome. Shernan, even before we take a dive into drug Axatilimab, can you touch on, so that we have some foundation around GVHD, differences between acute, chronic, what should we expect, and what does it really look like?
I have just such an important message for the community oncologists surrounding this. You have, possibly trained in an era where around half of our patients developed acute or chronic graft-versus-host disease, and up to around 12% of the time, patients would succumb to complications of graft-versus-host disease. Those who survived may have been left with substantial morbidity from chronic graft-versus-host disease, so much so that perhaps referrals weren't made for transplant, or a patient and family would decide, I don't want to trade one disease for another. I don't even want to go through a transplant. And that was completely understandable. Graft-versus-host disease has been a formidable opponent and really difficult problem to challenge clinically for many years. This is my most important message to community oncologists. Current graft-versus-host disease prophylaxis has markedly improved. We've had a transformation in our field that really started, I think, many years ago, but now has been confirmed with the results of a randomized phase 3 study, where we now have graft-versus-host disease prophylaxis that can actually prevent acute and chronic graft-versus-host disease in its most severe forms. Previously, graft-versus-host disease prophylaxis was really aimed at acute graft-versus-host disease, which was mostly GI side effects, so nausea, vomiting, diarrhea, and cutaneous manifestations, so an erythematous skin rash, and sometimes elevated liver tests. So that was the main thing that we wanted to prevent. That was the potentially fatal complication that patients might have. And then chronic graft-versus-host disease used to develop in that setting are close to 50% of the time, with varying manifestations from skin sclerosis to dry eyes, dry mouth, fibrosis, and damage of other organs as well, including lungs and liver. So really a multi-system disease that was very difficult to manage. With the current regimen that most centers are now using, based upon the phase 3 results of BMT-CTN 1703, post-transplant cyclophosphamide, tacrolimus, and MMF now results in a rate of life-threatening graft-versus-host disease less than 10% of the time. And that's both acute and chronic. So the severe morbidity of graft-versus-host disease is really a thing of the past with this regimen. And the mortality rate due to graft-versus-host disease is currently almost non-existent. So I used to say that around 12% of patients might die from graft-versus-host disease. With our current experience, the likelihood of dying of graft-versus-host disease is around 0.04%.
Which is amazing.
Wow.
So please take note for the community oncology members who are listening. Please refer your patients. It's a completely different era. In this talk, we'll be reviewing some treatments for chronic graft-versus-host disease, and we still have a number of patients who are suffering. We still want to help them. But going forward, we should honestly know this is a completely new era in transplantation.
Thanks so much for that beautiful message, and I cannot stress the importance of that. That's what you stated was 12% mortality to 0.04. That's just remarkable. And us in community oncology, we should be partnering up with tertiary or quaternary centers to have these patients undergo treatment because, again, there are better prophylactic drugs. And if one is suffering from GVHD, there are better treatment options, and one of them we will be talking about today. Thank you again, Shernan. Now, focusing on chronic GVHD, specifically, what are some of the available treatment options? This is before Axatilimab.
Yeah, chronic graft-versus-host disease used to be the land where we basically use the kitchen sink of immunosuppressants. It typically started with prednisone, and then we would add back potentially agents that we would often use in prophylaxis, like cyclosporin, tacrolimus, sirolimus. We might add mycophenolate as well. And then literally just the gamut of whatever immunosuppressants we could borrow from solid organ transplantation or rheumatology. We would borrow this or that and try these different agents and these combinations. And when you read reviews of management of chronic graft-versus-host disease, you would see a laundry list of 20 different agents to choose from. Here we go. Here's a small case series, and this is how it works. Very, very few limited data, limited controlled studies. It wasn't until 2017 that we had an FDA-approved agent to treat chronic graft-versus-host disease. So since transplant's been going on for over 50 years, that's how long it took to get an FDA-approved agent.
Yeah, no, it's remarkable how this field has moved. And you've touched on this, that even though we've made huge strides in preventing it, there still continues to be this unmet need, particularly in patients that are steroid refractory. And we have a few options here that were recently approved, including Axatilimab. So that brings me to this AGAVE-201 study. Shernan, can you touch on the novel monoclonal antibody that we're talking about here and the study design?
Yes, this is a unique drug. This is targeting myeloid cells for the first time in chronic graft-versus-host disease. So I'd mentioned that the kitchen sink approach of general immunosuppressants that are usually going to target T cells or B cells. So that first FDA-approved drug was ibrutinib, which our community oncologists will be very familiar with, targeting primarily B cells, but also T cells as well. Followed by belumosudil, which is a ROCK2 inhibitor. It's a nice immune modulator that has anti-inflammatory, anti-Th17, and anti-fibrotic properties. And then ruxolitinib, which the community will often have experience with for myelofibrosis. These agents were excellent to be able to have, but they were still kind of in that bucket of general immunosuppressants. They didn't really address the excessive fibrosis that can happen in the setting of chronic inflammation in chronic graft-versus-host disease. So this is a drug that targets CSF1R receptor on macrophages. So this is basically going to target your profibrotic macrophages, really the source of all of that scar tissue. And this is the first drug, to my knowledge, that would target the myeloid component of chronic graft-versus-host disease, actively, addressing the fibrotic phase of the disease. So this was a great study that, I appreciate that they took the approach of trying to dose find. Sometimes in phase ones can be pretty small, and we might not always find what we need in phase one studies. Sometimes we have to enroll more patients and iterate a little bit more to really refine what is the best dose. And in immunology, as you know, it's not always what is the maximum tolerated dose, but what is the best dose biologically. Those might be two very different answers. And so this study did randomize between 3 different doses. There's a low dose, which the study team actually thought was not going to be effective, but they thought it would be safe. So let's give this a try. 0.3 milligrams per kilogram every other week versus 1 milligram per kilogram every other week versus 3 milligrams per kilogram every 4 weeks. Either way, this is nice because it's keeping patients largely out of clinic. The most that people would have to come in for infusions was every other week.
And correct me if I'm wrong, Shernan, but the lowest dose was, in fact, the most effective and rather less toxic in comparison to the other doses. And that's what Rather employed. Yeah.
Exactly. When we all saw this plenary presentation at ASH, I think the entire room, kind of gasped, like, what? The lowest dose was the most effective? Probably because it was better tolerated, patients could actually stay on therapy. All these drugs have side effects. And so it was wonderful, honestly, to see that result that, giving the lowest dose actually has the best biologic effect.
Yep. Shernan, thanks so much for going on with that. This was rather a phase 2 study, but even with a small number, we saw some exciting results that led to this approval itself. So what did exactly the study show?
So what this showed overall is that patients who had extensive prior therapy for chronic graft-versus-host disease, I believe it was a median of 4 prior lines of therapy, but up to even like 9 or so prior lines, even in patients who had received every other treatment we had available, we still saw responses. And we saw responses across different organ involvement with chronic graft-versus-host disease as well. So being a multi-system disease, it was really nice to see that, yes, there's a good overall response rate, but this was really symptomatically meaningful too, because the organs where patients were having issues with quality of life, GI tract, skin, lung, we're seeing good responses really across all the different organs that were involved. I think we're showing here on the screen in particular the overall response rate at cycle 7. This is the phase 2 patient population. This is a 50%. Now, most of these are partial responses. We rarely get complete responses in chronic graft-versus-host disease, but it can be really clinically meaningful. If you can take someone who can have their skin ulcers heal, or their mouth ulcers heal so they can eat, or their skin restriction loosen up so they can take a deep breath, these are very meaningful things for quality of life.
Absolutely. These are exciting results. And again, the approval right now is for the lowest dose every 2 weeks. Shernan, even when we were getting ready for this presentation or discussion, you had shared a picture that we'll make sure to bring it up on this slide when we put this out. That picture has shown a dramatic response.
People really need to see what chronic graft-versus-host disease can look like and just how bad it can be. So the patient in the picture has extensive sclerotic changes of his skin and fascia, tight restrictions of limitations in movement, ulcerations, pain. This patient is basically immobile, and after treatment with axatilimab, had marked reduction in erythema, in pain, ulcers were healing. Interestingly enough, you'll see the picture, there's a dramatic improvement, but this was considered no response. So the way that we grade responses in chronic graft-versus-host disease, we borrow somewhat from the oncology literature. A complete response means, you completely resolve the deep hidebound sclerosis. That's probably never going to happen for some of these patients who have such extensive scarring. But there was such a meaningful improvement in quality of life. I want people to see just how much of an impact, even when we're seeing partial response and you're thinking, well, that doesn't sound that good, it can be super meaningful to patients.
Absolutely. And again, that picture is from back in 2019, so now almost 5 years ago. It also goes on to show the importance of enrolling our patients in clinical trial. We need to do better with this in our community settings because our patients get exposed to what is today's standard of care a lot sooner. So something that we always need to be mindful about.
Clinical trials are the ones which are changing the science, and we continue to learn from you as academicians. The interesting part about what you stated was no response, and that's something that you saw, at least visibly there was response, but not documented. I'm just wondering how many such responses were called as no response while they actually were visibly meaningful difference.
It could be a lot.
Yeah.
It has to do with how we score. So certainly there's the potential for benefit beyond our scoring system. And so that's why it's really important to look at patient-reported outcomes. And what's really nice, AGAVE did that. And many other trials are incorporating this. It's very important to get the patient perspective. We can do our grading. What really matters is how people feel. And you can see clearly there's improvement in quality of life on this drug.
Very true.
Absolutely. Again, coming back to now this available option, Shernan, we have a few available options in steroid refractory settings. Where and how are you going to sequence Axatilimab today in your clinic?
Based upon the label, it still has to be after 2 or more lines of therapy. But I'm going to be using this medication mostly in those patients who have more of a fibrotic manifestation, and ideally as early in the process as possible. We do have a lot of patients who are just waiting, though, that are, on other therapy, looking forward to receiving this. I think even though it's FDA approved, it'll probably be a few months before we actually have the drug in stock. And so we're doing our best to keep people, somewhat controlled until we can have this drug available. For me, this is mostly going to be those who have some fibrotic manifestations. We don't have good biomarkers to select therapy right now, but we do have experience. And I can say that there are different phenotypes of chronic graft-versus-host disease. If someone has a lot of active inflammation, you can see erythema. There's a ton of, clearly active inflammation. Maybe they'll respond well to immunosuppression, such as like ruxolitinib, belumosudil, or ibrutinib. Versus there's not as much inflammation. It's more of chronic fibrosis and change. Then belumosudil is going to be good there as well. And then axatilimab is really going to be our main player in that setting.
Now, we know this drug is effective and you're utilizing it, but for me in community, the biggest concern is the safety profile. What should we, as at least community oncologists, should know about from toxicity standpoint for axatilimab, infusion reactions, infections? What do I really need to worry about in community?
Yes. So this drug has some substantial side effects, as do any treatment for graft-versus-host disease. If there is a concern, please refer back to the transplant center. We're happy to take care of these patients. But if someone is administering this in the community setting, you should know that this is going to make some wild changes in the blood chemistry. One of the ways the drug is effective, of course, it's depleting macrophages, and that's going to include Kupffer cells in the general macrophage pool in the body. And these Kupffer cells in your liver have all kinds of enzymes, including your transaminases, your CK, pancreatic enzymes. And so after a dose of axatilimab, you might see that the LFTs in CK go up to the hundreds or maybe even thousands.
Wow.
This is wild, and it will scare everybody because the labs will come back and they'll have like multiple exclamation points and red italicized bold font. So you're going to have chemistry changes that look scary, and it will be difficult sometimes to sort out whether someone's having actual toxicity or progression of their graft-versus-host disease, or if this is just that depletion of Kupffer cells. The way you tell is by how the patient looks. If they look fine, they're probably fine. If they are having pain or if they're having clear progression of their graft-versus-host disease, then you're going to have to chalk some of this up to progression. But you will absolutely have to navigate these wild changes in chemistries that will improve over time as those Kupffer cells get depleted. So the first few doses, you're going to have some crazy lab values. You just have to tell everyone not to panic. As long as the patient feels good, we're okay. Now, other things to watch for, one of the other most common side effects was periorbital edema. This can be really bothersome to patients, but it is generally harmless. It doesn't affect vision, and it's fully reversible once the drug is stopped. Other issues to watch for can be changes in blood counts, risk of infection. That's usually just kind of the nature of the chronic graft-versus-host disease condition anyway. So it doesn't necessarily worsen any of those, but they're already susceptible to changes in blood counts and infections. So I would say by far and away, the thing that we'll notice are the changes in laboratory parameters. It can be really scary. You have to navigate that closely. But just listen to the patient and you'll be able to see how they're doing and determine dosing. I'm going to mention something that's off-label, but I think we do this when we're actually prescribing drugs in real life. If you are having toxicities, you can delay the dosing. You don't have to give it every 2 weeks. You just give them a little more time to recover, right? That's a very, very valid approach with this drug.
Shernan, there was another mention of infusion reactions. You've touched on the other one being periorbital edema. Are they somehow connected? And the infusion reactions, is it like what we expect with any other monoclonal antibody? Or is it something more serious like bispecific antibodies? And is this all connected?
Great question. It's more like any other monoclonal antibody infusion reaction that you might see like with rituximab or something like that.
Okay.
So, should be something that a community oncology team is well versed in managing. The periorbital edema is more of a later side effect, as the drug kind of accumulates in the body, and it has to do with the depletion of macrophages here as well. Over time, especially after you stop the drug, or if you just want to space out the drug, that does improve.
Dr. Holtan,
Correct.
thank you so much for walking us through this important topic and details around Axatilimab approval based off AGAVE-201 study for our chronic GVHD patients. For our listeners, let us go over a quick recap from today's discussion.
In today's discussion with Dr. Shernan Holtan from the Roswell Park Comprehensive Cancer Center, we had a chance to focus on the recent approval of Axatilimab, a novel monoclonal antibody against colony-stimulating factor 1 receptor. And now this is approved for chronic GVHD. Chronic GVHD can affect a good number of our transplant patients, though that number continues to get better. But when you have chronic GVHD, this can severely compromise quality of life.
In our discussion, we focused on AGAVE-201, a phase 2 study that showed a dramatic response with Axatilimab. Partnering up with tertiary or quaternary centers is very critical when it comes to managing these side effects that are associated with this particular therapy. But being able to address this locally, close to home, by being familiar with this agent and how to manage some of these side effects is the key being a community oncologist. Thanks for joining us. Make sure to check out our other discussions where we discuss recent approvals and the current standard of care for different malignancies. We are the Oncology Brothers.